to cover left atrial appendage, and my topic is undertreatment in left atrial appendage closure. So a little background, what do we know in this space? And we've talked about it for a little while. AF increases stroke by about 5-fold and accounts for nearly 20% of all strokes, particularly in patients that are over the age of 70. These patients have a higher bleeding risk and often take multiple medications, so these are the patients that typically would have drug-to-drug interactions and make long-term oral anticoagulation very problematic. Because these strokes are all cardioembolic and they tend to be larger and have more frequent and severe hemorrhagic transformations, that poses higher rates of recurrence and mortality for this patient population. Now, we've all had this echocardiogram in our echo lab for our patient in the upper right-hand corner where we've seen clot in the appendage. Now, this AFib affects nearly 7 million patients, and in actual practice, as we know, warfarin is severely underutilized. Even in patients who have had AFib-related stroke, only 30 to 70% are truly anticoagulated, and typically at 3 years, only 50% actually remain on the drug. We all know the problems of warfarin and keeping patients within a therapeutic range. Many of our patients are hospitalized for events with elevated INRs. Well, we thought the conversation was over with NOACs. NOACs definitely have been shown to have a favorable result by reducing intracranial hemorrhage. However, they've still not become the dominant therapy in the space, and there are a multitude of reasons. Whether it's cost, many of us are calling their insurance companies, lack of universal reversibility for strategies that happen with these agents, the need for twice-daily dosing for the more optimal agents, and at 2 years, at least 25% of these patients have discontinued a NOAC therapy. So if you look at it in totality, and we've seen this data, that only 40 to 50% of patients are on true oral anticoagulation and are compliant. We look at the ORBIT-AF trial, looking at nearly 10,000 patients. 13 patients were contraindicated for oral anticoagulants. And if you look at these patients who were contraindicated, they were typically older, had significantly higher incidence of stroke previously, prior MIs, kidney disease. These are your high CHA2DS2 score patients. Thus, it was felt that now the patients that are contraindicated for oral anticoagulation also would stand the most benefit from this therapy. We've seen the PROTECT-AF data showing the divergence in curves and non-inferiority of the therapy, but what we did see also in this space of concerns for peri-procedural safety, with nearly 5% of patients having pericardial effusions overall. PREVAIL subsequently really turned around our pre-med safety criteria and showed a significant reduction in events and peri-procedural complications, but in this case did not demonstrate non-inferiority. So looking at all the trials in totality, we do see a benefit in this therapy, but really these trials do not address the safety and efficacy of left atrial appendage occlusion in patients in whom oral anticoagulation is believed to be either relatively or absolutely contraindicated. And with more experience and improved intra-procedural imaging, as we've seen some of this today, we really have created a much safer procedure for our patients. So why aren't people that should be getting left atrial appendage closure not getting it? And I think you can define it into 3 different categories. One is procedural safety concerns. We know our experience in the past. Things have evolved over the space, but still an issue for an elective procedure that we're offering our patients. Some patients can't tolerate general sedation or general anesthesia. And a little bit about misinformation about the trials. Our current trials really are not enough to cover some of the complex patients that we see in our practice. So how do we address these issues? Well, we need improved intra-procedural guidance, and I'm going to speak a little bit on how we use fusion imaging in our laboratory. We need better and safer imaging. We've seen TE and we've also seen CT today. But what about IntraCardiac Echo guidance? And then lastly, we really do need studies looking at high and prohibitive risk patients. And hopefully with the data, even though slow enrollment of ASAP-2, we'll be able to answer some of these questions. So CT, I think, becomes a mandatory procedure or mandatory test as a pre-procedural scanning component for left atrial appendage closure. With this, you can see the orifice, you can see the body shape, you can understand better the bends, the lobes, and the true depth of a left atrial appendage. In this case, you can see the chicken wing, and you can understand how deep in the appendage you can get for an appropriately sized device. Doing centerline down that zone of the appendage, you can get the true length, understand optimal device sizing for any particular device, whether it be the WATCHMAN or the amulet. So I think this becomes an important therapy that we do TAVR CTs for our TAVR patients for aortic stenosis. Why can't we do this for this space to become a little bit more upfront in terms of planning for these complex procedures? We can also take this pre-procedural CAT scan, import it into our laboratories, and do fusion imaging. So with this CAT scans, you can segment out the different chambers of the heart here, the left atrial appendage, as well as the left atrium. Left is the Philips Heart Navigator system. On the right is the Siemens CT-Fluoro fusion system. And what you can see is once you segment out the appendage, you can identify and landmark the full depth of the appendage to get in this case, the WATCHMAN device deep for the appropriate size. You can choose a landmark your left circumflex artery, and then you can actually mark your landing zone. There are systems now that will allow you to implant virtual devices. And then you can rotate that C-arm to choose your best cranial-caudal position. So you can determine what your optimal view for deployment of the device. How does it look in the laboratory? Well, once you merge the CT imaging onto fluoroscopy space, you can overlay your landmarks. Here, transeptal puncture in this location, and you can landmark your left circumflex with an outline of the appendage. And you can see how it looks on both the Siemens and Philips and Siemens system, where you can really get a good coplanar angle, understand where your full boundaries of the left atrial appendage for deployment of the device. Well, if you decide not to obtain a pre-procedural CAT scan, you can still use fusion imaging technology. This is Echo-Fluoro fusion imaging. Well, using intraoperative echo imaging, you can overlay the images of the entire echo onto X-ray in addition to landmarks. So you can identify a landing zone as well as display live device deployment, whereby the operator, the interventionalist, can actually visualize the left atrial appendage orifice, in this case on the ultrasound, as well as the catheter for the delivery simultaneously. And I just put here on the bottom left-hand side, this is what our therapy looks like in our laboratory. I would argue that this would be the new way. On the right, our traditional approach, where we do an injection of the left atrial appendage, outline the appendage with a marker on the screen, and create our landing zone and deploy a device. I think this is archaic, and with all of our technology, we can do this in our laboratory. Lastly, what about IntraCardiac Echo? Now there's growing data in this space. This was presented at EuroPCR, a meta-analysis of nearly 1,100 patients. And using IntraCardiac Echo, there was shown to be a trend towards less procedure-related complications over TEE, with a similar success rate and similar fluoroscopy and procedural times. This is what the imaging looks like with a Siemens 3D probe, where you can see nicely with your probe planted within the left atrial appendage planted within the LA facing the left atrial appendage, you can obtain nice device size measurements, as well as on 3D see device deployment, and using your multiplanar reformats, your MPRs and double oblique projections, you can actually leave the probe in one position during deployment to confirm positioning, in this case, of your WATCHMAN device. We've just seen pictures of the new WATCHMAN Flex device, which is shorter, more anchors, more fabric, and I think the biggest feature is the fact that it actually has a closed distal end, that this is less traumatic for the patient, and I think less chance for procedural complications. So hopefully this will be out by the end of the year, and they're using it very aggressively in Europe. So to summarize, previously met unmet need of stroke prevention in patients unable to take long-term anticoagulation is currently being addressed with patients, but clearly there's a large undertreated patient population. Adoption of intra-procedural imaging guidance tools like fusion imaging and now newer tools of imaging like IntraCardiac Echo 3D may offer opportunities to further improve procedural steps and safety concerns for this procedure. Future research is clearly needed on expanded patient populations. Newer generation technologies and adjunctive therapies may help to close this therapeutic gap. Thank you very much.